Welcome to this video on male infertility. In this video, we'll specifically talk about semen analyses. What is it and how do we use it? My name is Dr. Ryan Flanagan. I'm a urologist and trained microsurgeon in male reproduction. Semen analysis, the what, who, why, when, and how. So what it is, it's a semen specimen that we then analyze. Who? Men of couples unable to conceive naturally for 12 months if they're less than 35 years of age, or if they haven't been able to conceive for 6 months of trying if they're over the age of 35. We perform them because we use it as an initial way to investigate for signs of male infertility. We typically get men to not ejaculate for 2 to 3 days prior to performing the semen analysis. And how we do this, typically once we get the semen analysis, which you can provide either a home sample and bring it in within 30 minutes, or if you produce it at the lab, an andrologist will then look at it under a microscope and make several different notes. So it provides several different variables for your doctor to look at and make sense of. One of the key things is the volume of the semen, the concentration of sperm, how those sperm are moving. So we refer to this as motility, and it could be broken down into total motility, so any moving whatsoever, or progressive motility. So these sperm are moving and progressing across the microscope slide when we're looking at it. Sperm morphology is referring to the shape and the appearance of the sperm. There's really strict criteria for this, and the sperm head has to be a certain size, a certain shape. The neck of the sperm has to be certain dimensions and shape, as well as the tail. Looking at the pH of the semen can also give us additional information to make sense of some specific scenarios. They also usually comment if there's round cells. Round cells can be either immature germ cells, so germ cells are sperm that haven't fully differentiated into a sperm yet, so you can think of it as baby or immature sperm, or this could refer to white blood cells or immune cells. And sometimes we'll also measure something called fructose, and in specific scenarios, this can be quite helpful for us as well. So how do we interpret the results? Well, your doctor will interpret your numbers relative to what we call the normal reference range. Here, if your values are above or below or even within the range, this will tell us a story and help us understand what abnormalities there might be, if there are any. So how do we arrive at the normal values or the reference range? Well, these are typically referred to as the 2010 World Health Organization normal values. This all came from a study that was very well conducted. In 2010, Cooper and several other colleagues retrieved semen samples from just over 4,500 fertile men across 14 different countries. What they found was that fertile men, where they defined as couples that were able to achieve a natural pregnancy in 12 months or less, were used as this reference range. They then looked at the lowest 5th percentile and drew a line in the sand at that point to determine what is acceptable within normal. So this means assuming that all of the samples will have values that are distributed amongst a normal population. So typically there will be many in the middle, and then there will be less on either extreme. So they look at the bottom 5th percentile of men that are still able to get a pregnancy within 12 months, and they define that as the lower limit of normal for a normal reference range. So when we look at the actual data from the study, you can see here on the left-hand side with the red box are the variables associated with the semen analysis. If you look at the red box in the middle of the slide, you can see this lower 5th percentile. So as a result, we see semen volume is 1.5 cc's, is a lower limit of normal. We see that sperm concentration is 15 million. Total sperm count is 39 million. Total motility, 40% or higher. Progressive motility is 32% or higher. And normal forms where we use strict criteria is 4% or greater. So at least 4% of the sperm have to match this very specific, perfect sperm shape and size to be considered normal. And finally, the viability or the number of sperm that are alive have to be 58% or higher. So this is how we arrived at what we call the normal reference range and what we compare your specimen to when we're interpreting the results. Now, there's a lot of importance in doing two CIMA analyses, especially if the first CIMA analysis shows that there's an abnormality. We'll typically want to repeat it a second time because there's a lot of variability. Now, there's typically two general reasons why there can be variability. One, there's variability in the analysis. So the person looking at the sample, if we had one sample examined by multiple people, we might get slightly different values. Another reason is that there's biological variability in sperm production and quality. So the sperm that you produce today might look a little bit different than the sperm you produce next week, which might look a little bit different than the sperm you produced a year ago. So if we look at a study examining for technical variation, this particular study that was performed a few years ago in 2012, they measured something called the coefficient of variance amongst different centers evaluating the same specimen. So basically what this is referring to is how much variability there is around the measured values from center to center to center, looking at the exact same specimen. The bottom line in this study is that there was a large amount of variation in sperm counts amongst multiple locations measuring the exact same specimen. And this isn't just limited to sperm concentrations, but all of those other factors as well. This is just used as one example. There's another study that was performed a little bit longer ago, 2004, that really captures the amount of variation within one person over time. So in this study, they had 12 healthy volunteers that produced somewhere between 5 and 10 monthly CIMA analyses over a 12-month period. So over 1 year, it was just under 100 CIMA analyses that were produced. So what they found was that there is huge variability in all of these factors. The volume varied nearly twofold difference from the same individual over time. Concentration varied by almost a multiple of 5. Progressive motility varied by a multiple of nearly 3. And the morphology, so that strict shape, varied by almost a factor of 2. So if we look at these results a little bit differently in the form of a graph, each of these clusters of bars on the graph, they're labeled as A, B, C, and up, represent an individual patient. And then the y-axis, or the vertical aspect of the graph, refers to the sperm concentration. So for each of those clusters represents one patient, and the difference in heights of the bars within each cluster represents all of the different measurements or the variability in sperm concentration per patient over time. As you can see, the huge variability in the bars, there's a lot of variability in production over time. This is the same for progressive motility. Again, same definitions for the x and the y-axis of the graphs here, but you can appreciate that there's a lot of variability even in the movement. CIMA analyses can be very helpful. However, there is a caveat that there's certainly limitations with what we can do with the CIMA analysis. In many cases, what we'll be looking for is identifying reversible factors in a person's fertility and medical history, as well if there's any abnormalities on physical exam that might be associated with a specific CIMA analysis finding that may trigger your doctor to look into a specific region. However, in some cases, advanced reproductive techniques might be recommended based on the results. An example might include intrauterine insemination. Here, we typically look at the total motile sperm count. So this is the volume of the semen multiplied by the concentration of sperm multiplied by the total motility. So as a result, this is the total number of moving sperm. In order to successfully perform intrauterine insemination, most labs will typically use a lower threshold of about 5 million total motile count. There is some variability from lab to lab, and it's best to check your specific lab for this threshold, but it's an example of how we might use the results. For IVF-ICSI, we can typically have this achieved with very, very low numbers of sperm. So if we have a concentration less than 1 million, or we have literally tens to hundreds of sperm, this can typically be achieved, as we just need one viable sperm per egg. So in summary, interpretation of CIMA analyses is based upon normal reference values, which is based upon the lowest 5th percentile amongst fertile men as per the World Health Organization. There's a lot of variability that exists from test to test, as well as within an individual due to biological reasons. CIMA analyses are an imperfect test, but they're still quite helpful in guiding fertility treatment recommendations and helping us guide your therapy. Thanks for watching this video. If you'd like more information, feel free to visit my website or the YouTube channel listed here and my Twitter handle below. Thanks very much.